Hi, I'm Mona Williams-Gregory, and today's lecture is on role transition, specifically for nurses who are in the RN to BSN program. Today we will appraise the rationales for becoming baccalaureate prepared. We will differentiate between associates and baccalaureate programs. We will also evaluate our current level of skill acquisition and reflect upon fear, marginalization, and role transition. So why become BSN prepared? So in 2011, the Institute of Medicine published a call to action, and the call was to increase the number of baccalaureate prepared nurses by 80% to 80% by the year 2020. The IOM states that baccalaureate prepared nurses have the skills, knowledge, and abilities needed to manage complex patients and healthcare systems. Specifically, the IOM states that baccalaureate prepared nurses demonstrate knowledge and competence of health policy, system improvement, research, evidence-based practice, teamwork, collaboration, leadership, and complex decision making. The literature consistently demonstrates that improved patient outcomes are associated with baccalaureate prepared nurses. Earning a BSN is associated with quality, it garners more respect, it increases our earning potential, and it improves professional opportunities. Bloom's taxonomy is a model that classifies learning objectives into levels of complexity. The base of the model, remembering, depicts lower levels of complexity. More complex, higher level thinking increases as we move up the model towards its peak. So let me give you an example, and I'd like you to guess. So if you take a look at the action words over to the right of the model. So if I give you a case study in class and ask you to repeat or state the information from the case study, I'd like someone to take a guess as to what level in Bloom's taxonomy those behaviors would be reflected in. So again, if I give you a case study and I say, Susie, can you please state, can you please repeat the patient's previous medical history? So where do the behaviors state and repeat fall into Bloom's taxonomy? Correct. So state and repeat, as you see, are lower level behaviors that are associated with the remembering level in Bloom's taxonomy. Good. So in contrast with that same case study, if I ask you to use the nursing interventions in the care of another patient, Joseph, where do you think use falls under Bloom's taxonomy? Good. So if we look at the apply level in Bloom's taxonomy, those verbs associated there are execute, implement, solve, use, and demonstrate. So the curriculum in the associate's degree program prepares its graduates to pass the NCLEX RN examination and to function as entry-level nurses. ADN programs prepare its graduates to function at the application level of Bloom's taxonomy. In contrast, baccalaureate programs prepare its graduates for more complex, higher level thinking that occurs as we move up the pyramid towards its peak. So Dr. Patricia Benner introduced the concept that expert nurses develop skills and understanding of patient care over time through a strong educational base and through recurrent clinical opportunities. So Dr. Benner described her stages of skill acquisition along this continuum. So the first stage in the continuum is the novice. The novice is the brand new graduate, the nursing student or graduate nurse who has no experiential base, they lack confidence and need continual support. The next stage is the advanced beginner stage. And in the advanced beginner stage, the nurse uses procedures and pretty rigid rules to guide their actions, and they require continual support. Competent nurses are task-oriented, And they deliberately structure their work to attain goals and don't need the support that the lower levels do. Competent nurses can respond to many clinical situations, but they lack the ability to recognize clinical scenarios, clinical situations on a grander scale, on the larger picture. And then we have the proficient nurse who perceives situations as a whole and on the larger scale. They have a greater ability to recognize and respond to changing circumstances. And the highest level of skill acquisition would be the expert nurse. The expert nurse recognizes unexpected clinical responses. They're alert to potential complications even before they occur. The expert nurse is able to accurately diagnose and respond to ever-changing clinical scenarios without wasting valuable time considering interventions that are not going to be successful. So next we have a video of Dr. Patricia Benner's novice to expert model. This is for our visual and our auditory learners. So this is an 8-minute video that explains Dr. Benner's model. Obviously, for time's sake here, I will not play it. But again, this is for my visual and my auditory learner. It goes back over Dr. Benner's stages. So after the video plays, for our kinesthetic learner, we now break into small group work. So students, using the handout that has been provided for you, please identify your current level of skill acquisition. So Dr. Benner's novice to expert model is summarized for you at the top of the paper, and down at the bottom, or in the middle, it asks you to identify your current level of skill acquisition. And there are 3 sections. I'd like you to give 3 clinical examples that depict your current level of skill acquisition. Please break into groups of 4s. I'm going to walk around and I'm going to help you. So what I also want you to keep in mind is that in certain scenarios, you may be competent. In other scenarios, you may be proficient. In other areas, you may be a novice. So recognize that this is a fluid classification of yourself depending upon where you are. You may be very comfortable in the unit that you were a nursing assistant in, so you may be competent there. But when you move to the med-surg unit as a brand new graduate, you may now be a novice. So I just walk around and I kind of help them work through this. So we take 3 to 5 minutes in the small group work, and then we work together as a class. Would anyone like to share their classification of their current skill acquisition? Would anybody like to share some of their clinical experiences? Thank you for sharing. After we do the small group work and the large group work, then we reflect. So let's take some time to discuss the feelings associated with this exercise. Is anyone having any apprehension about role transition? Is anyone nervous about the changing expectations that might occur by your employer, by your unit manager, by your charge nurse? Does anyone have any feelings that they would like to share? And we share, and we debrief, and we talk about how to overcome fears, how to handle conflict resolution, professionalism. Is anyone familiar with marginalization? Does anyone know what marginalization is? Marginalization is when it's the process that occurs when someone negates your value by relegating you to a position of unimportance. So let me give you an example of my personal experience with marginalization. So I was a registered nurse in an emergency room, and I decided to go back to become a nurse practitioner. I did my last clinical rotation in the same emergency room where I was a nurse. After graduating and passing my state boards, they offered me a position to be a nurse practitioner in that emergency room. So to me, it was the best of both worlds. I already knew the computer system, I already knew the people. So the only thing I had to become accustomed to was the new role. Well, much to my surprise, and pretty early on, I noticed that my nurses, my peers, my friends were not pulling off my orders, but they were pulling off other people's orders quickly. my orders, if I ordered to have an IV started or to give a medication or to send a patient to CAT scan, I noticed that my orders weren't being carried off. And so there were times when I actually had to start my own IV or give my own medication because the time lapse was just, it wasn't good for our patients. So, of course, I'm brand new to this role and I was very nervous about having the conversation. So it took me a while to get up the guts to have the conversations. But when I started talking to my peers, they all said the same thing. Oh, well, we know you know how to put in an IV, put in your own IV. Start your own medication. We're busy. We need to concentrate on those that can't do it. So that's how I was marginalized. So let's talk about how you can work through that situation if you find yourself in a similar situation. So this is where we do large group reflection. It's important for us to make sure that even if something like this happens, that we are professional at all times. We need to maintain professional communication. And when we become flustered and upset, take a moment, take a step back. And again, always address things professionally, even when someone is doing something as unprofessional as not pulling off an order because they know you know how to start an IV. So, if you find yourself being marginalized, then you have a decision to make. Unfortunately, sometimes staying in the same location after a role transition is not conducive. Sometimes you have to make a change in order to function in the full capacity of your new role. But remember, everything happens for a reason, and growth does not occur without discomfort. Thank you for your time.